This is a oral drug that's given once a week. More recently, we've rolled some of the paraganglioma patients over to a more dose-intense schedule of 2 consecutive days each week. The drug acts through the DRD2 receptor to cause a number of downstream effects, including trail, but also you can think of it as an integrated stress response. It also works through the AKT and HERT pathways. But instead of being toxic when you inhibit dual pathways like that, this drug has been extraordinarily well tolerated. So not only a oncologist dream, but research nurses too, because you don't have as many AEs and SAEs to report. About half the paraganglioma patients have responded by RECIST criteria. The responses don't happen right away, but it can be at 6 weeks, 3 months, or even 6 months to have your best response. What I've also seen with the drug is a maintenance of quality of life and clinical benefit. So when you look at things from the perspective of a patient, what counts is, are they able to maintain their activities, work, go to school, things like this. So that's been very good. And then probably the nicest thing is it's taught me how to be very organized about rare diseases, how to help patients kind of weigh the indications, the risks, alternatives. I'll get a lot of different phone calls or emails. Should I go on ONC201? And often I'll be able to do either an online consult and follow it up with a FaceTime or a virtual visit, which is a very kind of relaxed conversation with the patient. And they're highly motivated, so I'll say, what I'd like you to do is send me a short summary. I don't need the big stack of medical records. With that short summary, plus if you send a CD, we'll upload it, or you upload it. Call this number to get a medical record number, then we'll decide if this is appropriate for you. So if you do your homework before they walk into your clinic, it makes it much easier to have that discussion about consenting and what are their responsibilities on the study. So it's kind of a new way for me to, before COVID, I was doing a lot of virtual visits, but it's also shown me that Cleveland Clinic is extremely well set up to do virtual visits as a pre-screening tool, if you will. And so there's less disappointment and also this less high risk, am I going to be eligible for the study or not, kind of thing when they come. Once they're on the study, then it's usually smooth sailing. What I try to do is make the routine things predictable. So my research nurse and I will prepare a calendar. So we don't schedule follow-up scans and stupid dates, or when I'm on vacation or things like that. If their scans are quite complicated, I'll make sure they get them the day before I visit them, so I can look at all the indicator lesions, capture them on a PowerPoint, put them into an Excel spreadsheet, so they get their not only yes or no, are you stable or improving, but also seeing things is much better than getting a report. Sometimes they're quite complicated. So I would say what the study has done is shown a paradigm for both being on a research study, but also getting the best of both worlds, really personal and personalized therapy that helps you. I've been able to do that partly because I wrote this study. So it's an investigator-initiated IND. So some of the things we'll run into with metastatic patients are their indicator lesions responding or stable, but they have a painful bone metastasis. What do you do? So if they're getting clinical benefit, you are allowed to do cryoablation or SBRT of the painful lesion. So they want to drop off the study to take care of something that really is not life-threatening, but uncomfortable. So I think it's a good model for how you can take a drug at an early stage, treat a rare disease, find out useful information, and be able to actually get enough patients to learn that it works.